Thank you. Thank you, Dr. Sneha Panchal, for the wonderful presentation. We will keep the question answer sessions at the end of the session.
Thank you, ma'am. Next, we have cryoneurolysis of peripheral branches of trigeminal nerve. For this, please welcome Dr. Smruti Rekha Hota, pain physician associated with Relief Spine and Pain Clinic, Sambalpur, and Daradia Pain Clinic, Kolkata.
So, good afternoon, everyone. Today, I will be presenting cryoneurolysis of peripheral branches of trigeminal nerve. So, these are the terminal branches of the trigeminal nerve. As you know, the facial pain, particularly trigeminal neuralgia, is the most excruciating pain condition. And here patients describe is at electric shock-like and stabbing pain that completely disrupts the quality of life, and we know it as suicide disease. While medications are the first line of treatment, many patients either fail therapy or develop any side effects or remain partially controlled. That is where interventional technique become vital. So to understand the interventions, we must revisit the anatomy of the trigeminal nerve. I will not discuss much. As we all know, there are three branches, main branches, V1 ophthalmic, V2 maxillary, and V3 mandibular. Here, our target for the cryoneurolysis are those divisions which are accessible through percutaneous interventions, like supraorbital and supratrochlear branch of V1, and infraorbital and zygomatico-vesial branch from V2, and mental and auriculotemporal from V3. We should know the branches, and accurate anatomical knowledge is vital for the procedures, as cryoneurolysis targets them precisely without damaging deeper structures. So what is cryoneurolysis? It is the controlled application of the extreme cold, usually between -60 to -80 degrees Celsius, and that is delivered through a cryoprobe. That cold forms an ice ball around the nerve, and it causes Wallerian degeneration. Importantly, the epineurium and perineurium are preserved here. That will allow the nerve to regenerate over 3 to 6 months. That means we achieve a long-lasting pain relief without any permanent nerve destruction. So why we choose cryoneurolysis? Because cryoneurolysis mainly useful for trigeminal pain, and it can all be also helpful for the only peripheral branches. Suppose mental nerve is involved. So why to do a more invasive procedure if we can access through the peripheral branches? So firstly, it is very minimally invasive and it can be repeatable. Secondly, unlike the chemical neurolysis or RF, it doesn't risk deafferentation pain or crosstalk or any permanent numbness. And third, it provides a middle ground between the conservative and pharmacological treatment. So what are the indications? Classic trigeminal neuralgia, where pain is localized to a single branch, like mental neuralgia, infraorbital neuralgia, or supraorbital supratrochlear neuralgia. Then post-traumatic trigeminal neuropathy. For example, after dental extraction, inferior alveolar nerves are affected, so that's where we can do mental nerve block. And then post-herpetic neuralgia, where involving the trigeminal branches, like supraorbital, supratrochlear are most commonly involved. And chronic idiopathic facial pain with localized peripheral triggers. In carefully selected patients, the results are very gratifying. So contraindication, of course, not everyone is a candidate. It includes active local infection, coagulopathy, and unrealistic patient expectation, those who are expecting 100% pain relief. A good pre-procedure counseling is important, that's why. Then, now technique, the patient position. And all the three, these are facial interventions, that's why patient position is commonly lying. Supine position, head, either in neutral position or slightly extended, and under anatomical landmark guidance or preferably ultrasound. But nowadays, landmark technique is almost obsolete. That's why we prefer ultrasound, and we identify the target nerve. Then local infiltration is done, And cryoprobe is advanced percutaneously adjacent to the nerve. And one more important thing, you should not go deeper into the foramen. So we are not targeting the deeper branches. We are targeting the nerve that exiting through the foramen. So here, cryoneurolysis, what is the process? It is the freezing and defrosting that started at a temperature of minus 70 to 80 degrees centigrade and for 3 minutes or 180 seconds. And tip of the probe achieve a cooling temperature of maximum minus 78 degrees centigrade. You can see the ice ball formation as a posterior acoustic shadow under ultrasound that I am showing next. So we should be familiar with the cryoprobe. So it is a probe. You can see for the peripheral branches, we use a 2 millimeter of the cryoprobe. And that 2 millimeter cryoprobe can form a lesion of up to 5 to 8 millimeter of size. It can maximum 1 centimeter lesion we can create through the cryoprobe. So no need to touch the nerve also. Even if we keep the probe adjacent to the nerve, we can create a lesion of 1 centimeter. So this is the cryo machine, and you can see the lesion, that is the ice ball formed through the probe. What are the advantages? The most important, minimally invasive. We can repeat as many times as we do want, and there is no risk of deafferentation pain and preservation of normal sensation even after recovery. And one most important is immediate pain relief in the OT table. And limitation is the effect is temporary, that require precise location. And yes, now RCTs are coming, but still limited. So you can see the probe position. This I have taken from my mentor, Dr. Gautam Das, and these are the procedures that I have done in Daradia Pain Clinic. So for the mental neuralgia, you can see the probe position exactly over the mental foramen, 2.5 centimeter lateral to the midline, and at the center of the chin. And infraorbital neural nerve, you can target just below the infraorbital rim, inferior orbital rim. So these are the 3 cases that I have performed with Dr. Gautam Das sir. And here, a 45-year-old gentleman that has severe infraorbital neuralgia after dental extraction, and medications was ineffective. He was losing weight due to pain on chewing, not able to eat his food. We performed the ultrasound-guided cryoneurolysis of the infraorbital nerve, and that lasted for 5 months. And you can see the position of the probe in that female. You can see the location of the probe. It's not gone deep inside the foramen. It is just at the entrance of the foramen. And you must be seeing some blood vessels also along with the nerve. It goes. You must be thinking, what about the nerve? If it got damaged, nothing to worry. Blood vessels, they may got frozen, but collaterals may form. So damaging the blood vessel is not an issue. Then second case, this is a 67-year-old male with past medical history of diabetes and hypertension, presented to our clinic with persistent sharp-shooting electric shock-like pain in the left jaw. And the pain started 7 years before the initial presentation, where he was diagnosed with mental neuralgia. That pain was also severely impaired, and the patient's quality of life, he is also diabetic and hypertensive, I forgot to mention. You can see the probe position, and the probe tip is kept adjacent to the foramen, and you can keep it 1 mm, 2 mm above the foramen also. And how the mental foramen looks under ultrasound guidance, it will look like a bridge in the continuous bone. So okay, you can see the bridge, and just where you can see that bridge, you just put your probe above that. And there is mental artery and blood vessels will be also there. You can check through the color Doppler. And you can see the ice ball formation in the third picture. And this is another case, 62-year-old female with persistent left-sided forehead pain for 8 months. And it was described as burning, stabbing, and electric shock-like with allodynia, to touch over the left supraorbital and supratrochlear regions. History revealed an episode of herpes zoster ophthalmicus 10 months earlier, after which pain persisted despite resolution of the skin lesion. On examination, there was tenderness over the supraorbital notch and supratrochlear region with hyperalgesia and sensory changes along the distribution of ophthalmic division, and visual acuity was preserved. Diagnosis was PHN that involved supraorbital and supratrochlear nerve, and the patient had failed trial of all the neuropathic pain medications. Now you can see the position of the probe. Supraorbital, it is just at the supraorbital rim, that foramen, and when you move medially, when you move your probe medially to the supraorbital foramen, you can find the supratrochlear foramen. So at one time you can proceed both the block or both the ablation. You can see the post-herpetic lesion is there. And either we can go from medial to lateral for supraorbital and supratrochlear, the same direction. You can see the probe position, and it is very superficially at a depth of 0.5 centimeter or 5 millimeter. So this is how we perform the procedure, and all the 3 patients had a good pain relief of minimum of 3 months duration. So please give me 2 minutes. Outcomes, so what outcome we can expect? The most studies report immediate pain relief in 70 to 90% patients. Duration of relief that ranges from 3 to 6 months, and since the nerve regenerates, procedure can be repeated without cumulative damage. For example, in one case series of infraorbital neuralgia, 80% of patients remain pain-free for at least 4 months with repeat cryo providing similar relief again. But in case of RFA, you might have noticed the first radiofrequency ablation of the trigeminal neuralgia. The second time when we repeat it, there may or may not be that much relief. And then in future direction, looking ahead, the role of cryoneurolysis is expanding, and there is growing interest in combining cryoneurolysis with regenerative injections like PRP to enhance its recovery of the peripheral nerve, and with better USG probe, precision targeting of even smaller peripheral branches will be routine. And I believe cryoneurolysis will soon become a standard step in interventional pain ladder for any trigeminal nerve peripheral branches pain. Thank you so much.
Dr. Smruti Hota, she needs no more introduction. It was a very insightful, nice presentation. We'll keep the question answer session at the end of this session, and we hope we have so many questions to ask her.
Thank you, ma'am. Now I would like to welcome Dr. Anamol Huck Milton, consultant at Spring